In over 2 decades reading brain scans in the radiology unit, I've lost count of how many patients came in with a massive stroke, paralyzed, unable to speak, after taking one of these 3 medications the night before. The worst part? Every single one of them was prescribed by a doctor. Today I'm going to show you who these villains are and how to protect your brain before it's too late. And look, the last one on this list is going to shock you. It's a pill sitting in the medicine cabinet of almost every adult over 60. Could it be in yours? But first, hit the like button. Subscribe so you don't miss any of our health tips, and turn on the notification bell. And please spread this knowledge with your friends and family. By sharing, you could literally save the life of someone you love, and they will be grateful for the rest of their lives. So share it and let me know in the comments, have you or someone you love ever had a stroke? Did you suspect a medication? Write it below. But before we dive in, an important warning. This video does not replace your doctor's advice. Do not stop any treatment on your own. What I want you to do is walk away informed, so you can have a better conversation with your physician. That is the entire point. Ready? Let's expose these villains one by one. Villain number 3. And you've almost certainly used this one. You know the scenario, right? You wake up with a stiff neck or a throbbing headache. You reach into the cabinet and grab an ibuprofen. Back aching after a long week, naproxen, shoulder flaring up, diclofenac. It feels completely routine. These are the best-selling medications on the planet. Your doctor may have recommended them. The pharmacy sells them without a prescription. But here is what happens inside your body when that pill dissolves. Your blood vessels have a natural protective lining, endothelial cells that produce a compound called prostacyclin. Its job is to keep your vessel walls relaxed and prevent your platelets from clumping into clots. When you take an NSAID, particularly diclofenac or high-dose ibuprofen, you suppress the enzyme responsible for producing that protection. The vessel walls stiffen, the platelets get stickier, and in a brain artery that already has some degree of atherosclerosis, which is extremely common after 60, that combination can be enough to trigger an ischemic stroke. I'm not speculating. In 2011, when a large Danish cohort study published in the British Medical Journal tracked over 100,000 patients and found that diclofenac was associated with a significantly elevated risk of stroke, even at standard doses and within the first weeks of use. A 2017 review in the European Heart Journal reinforced those findings across multiple NSAID classes. The practical guidance here is straightforward. For occasional mild pain, acetaminophen, Tylenol, is a considerably safer option for your cardiovascular system. For chronic pain management, that is a conversation worth having specifically with your doctor, because the risk-benefit calculation depends entirely on your individual history. The point is not to panic about one ibuprofen you took last Tuesday. The point is that long-term, regular use in someone over 60 with any vascular risk factors deserves a real conversation, one that a lot of patients are never having. Villain number 2 is one I want to handle carefully because the medication itself is genuinely important for many people, and the risk I'm describing is specific and contextual, not a reason to stop treatment. SSRIs, selective serotonin reuptake inhibitors, sertraline, fluoxetine, escitalopram. These are among the most commonly prescribed medications in adults over 60, and for good reason. Depression in older adults is underdiagnosed and undertreated, and these medications save lives. But here is what many patients are never told. Serotonin plays a role not just in mood, but in platelet activation. Your platelets use serotonin as a signaling molecule when they aggregate to form clots. SSR is deplete the serotonin stored in platelets. On its own, that effect is modest. But when an SSRI is combined with NSAIDs, which, as we just discussed, are also affecting platelet function, or with anticoagulants, or even with daily aspirin, the interaction compounds significantly. A study published in the British Medical Journal found that the combination of an SSRI with an NSAID was associated with a risk of intracranial bleeding, hemorrhagic stroke, roughly 15 times higher than taking neither drug. 15 times, not 15%, 15-fold. Again, this is not an argument against SSRIs. It is an argument for your doctor knowing every single medication and supplement you are taking simultaneously. That list matters. Combinations matter. And research consistently shows that a significant proportion of older adults are taking drug combinations that their physicians are not fully aware of, because different medications were prescribed by different specialists who never compared notes. The action step here is simple but important. Pull out your full medication list, including over-the-counter drugs, supplements, and anything you take occasionally. Bring that complete list to your next appointment and ask your doctor directly. Are any of these combinations a concern for stroke risk? That question takes 30 seconds and can change everything. And now the one I told you would surprise you. Testosterone replacement therapy, gels, injections, pellets, and for women, certain combined hormone replacement formulations. This is the one I see most often going undiscussed. Because the clinics prescribing it are growing fast, the marketing is compelling, and the way patients feel in the first weeks, more energy, better mood, improved strength, is real enough that the risk conversation gets skipped entirely. Here is what happens physiologically. Testosterone increases red blood cell production, a process called erythropoiesis. More red blood cells means higher hematocrit, which means thicker, more viscous blood. And thicker blood moving through cerebral arteries that in a 65-year-old may already have some degree of narrowing or plaque is a significantly elevated stroke risk. This is not theoretical, it is the mechanism. A study published in PLOS1, tracking tens of thousands of men, found that testosterone therapy was associated with an increased risk of stroke, particularly in the first year of use, and particularly in men who had not had a confirmed deficiency diagnosis prior to starting treatment. A 2023 randomized controlled trial, the TRAVERSE study, found that in carefully selected and monitored patients, cardiovascular risk was not significantly elevated. The key words there are carefully selected and monitored. That means baseline blood work, regular hematocrit checks, an endocrinologist or experienced physician managing the protocol, not a wellness clinic running a volume business. For women, the picture is similarly nuanced. Combined estrogen-progestin formulations, particularly oral versions, have been associated with elevated clot and stroke risk in observational studies. Transdermal estrogen, patches, gels, appears to carry a lower risk profile, though individual factors matter enormously. The message here is not that hormone therapy is categorically dangerous. It is that it is not categorically safe either, and that the conversation you have before starting it should include a direct question about stroke risk, your personal vascular history, and what monitoring will look like while you are on it. If your prescribing physician cannot answer those questions specifically, that is important information. Let me bring this together. 3 medications. NSAIDs like ibuprofen and diclofenac used regularly, SSRIs in combination with other platelet-affecting drugs, and testosterone or hormone replacement therapy without proper screening and monitoring. 3 different mechanisms. 3 conversations worth having with your doctor. The ask is not complicated. Take this information, write down the names of anything on this list that applies to you, and at your next appointment say, "Given my age and my history, is my current medication combination a concern for stroke risk? Is there anything here we should revisit?" That single question, asked by an informed patient, changes the quality of that appointment. You are not demanding they change anything. You are opening a door. Doctors generally welcome that door being opened. Do not stop or alter any medication based on this video alone. That is not what this is for. Now, if that was the warning side, you might be wondering what the protective side looks like. Because there are medications and interventions with solid evidence behind them that meaningfully reduce stroke risk in adults over 60. If you want me to cover those, the ones that the research actually supports, write the word protect in the comments. If enough of you ask, I'll record it. And if someone in your life is over 60 and takes any daily medication, send this to them. Not because I asked you to, because stroke is largely preventable and most people don't know what to ask. My name is Dr. Ivy Ellington. I'm a radiologist. Subscribe, and I'll see you in the next one.